All right, this is the Health Assessment Comprehensive Overview for your final. Just as always, take notes, take copious notes. If I say it once, I say it twice, I say it a third time. Expect it to be a portion or a piece of what you're supposed to know for the final examination. It's that simple. So let's just blow through it as fast as we can, and hopefully this won't take too long. All right, so we're going to go back and review about acute pain versus chronic pain. Acute pain, it's going to be recent onset. It's going to be tissue damage normally. It's usually self-limiting, which means it's only going to get so bad and then it starts to level off. And then when the tissue's healed, it's considered to be healed as well. So a person who's had a surgery of some sort in the last, 24 hours or less, that would be considered an acute onset of pain versus a chronic or persistent pain, which we used to say was the definition of 6 months or greater, but it's actually 12 weeks or greater. And it is a condition that persists despite medication or treatment. So patients who are getting chemo and have been on chemo for cancer for 3.5 months. Someone who has had severe pain for decades, right? That'd be a chronic patient. Someone who has been treated unsuccessfully for the past year for a high school knee injury, right? That would be considered, again, a chronic patient because we're over that 12-week threshold. So we can go to the next slide. All right, so I always get silly questions, and this is probably one of the silly questions I'm going to get. So I have 4 types of pain. I've got somatic, neuropathic, referred, and visceral pain. All you need to know is the differences. And guess what I'm going to get a question on? Which one of these do we need to know? The answer is you need to know all of them, right? Because I've already weeded through all the information that you need. I've already done all the hard work for you. So of all the different types of pain that we could get into that go far beyond the reach of these 4, I'm choosing these 4. Know these 4, okay? So know that at some point you're going to need to answer and identify. So like you're going to have a patient with, a history of rheumatoid arthritis, all right? They're complaining of severe throbbing pain in the great toe. All right, so what type of pain are they experiencing? Well, if they're having a joint pain or a muscle pain or a connective tissue pain that's aching or throbbing, it's causing a detriment in the quality of how they can function as an adult, and it's located, then that is all somatic pain. See how that works? All right, so know that and know how to identify it if there's a question about it later on in life. So let's go to the next slide. All right, so I wanted this final to be heavily focused on assessment because that's what we have been doing the last couple of weeks is assessing people. So I need for you to know flexion, extension, internal rotation, external rotation, what that looks like. So external rotation and abduction of the shoulder, it's going to be tested by asking the patient to put your right arm behind the head. Know that that is specific to that type of rotation and abduction of the shoulder versus flexion of the elbow requires the patient to flex the elbow. But it's tested by asking the patient to bend the elbow so that the fingers are touching the shoulder. You're going to have the scenario where you're going to need to know what that movement means. Okay, so know what it means to do these 4 things and you should be good to go. Next slide. And again, here we're going to go over supination versus pronation. We're going to talk about how the elbow moves, and then we're going to talk about flexion of the wrist, extension, and then deviation of the ulnar and radial aspect as well. So just know what these mean. There's no tricks today, no tricks. Step right up, there's no tricks to be had. All right, next slide. All right, so fat-soluble vitamins. You have to do 4, A, D, E, and K. And for whatever reason, A, D, and K is listed, but not E. So I'll add E. So if someone is, having a deficiency of A, D, E, and K, what does that mean? If someone has a specific diet, like say they're a bodybuilder. If they're a bodybuilder and they keep under 18% fat, what does that mean they're going to be deficient in? Well, what are the fat-soluble vitamins, A, D, E, and K? Well, what are the water-soluble vitamins, all the others? There's not a whole lot to do as far as thinking ahead. All you need to know is if there's a deficiency fat soluble, then we're A, D, E, and K deficient. If we have too much of, then we have too much or a malabsorption or hyperabsorption of those A, D, E, and K vitamins. That's it. That's all there is to it. And then recall iron absorption, zinc, and vitamins B and C have nothing to do with anything related to A, D, E, and K because they're either not affected by low-fat intake or they're specific to just being water soluble. So it's not going to affect any type of fat solubility because of how they're predisposed. So next slide. All right, so when we're talking about lesions, assessment of lesions is pretty simple. All right, so you got to use a centimeter ruler, you measure the size of the lesion. It needs to be documented based on its characteristics, like its location, its distribution, its color, its pattern, its edges. Is it flat or raised? What's the size, right? So again, comparing its size to the size of a coin is a great way to do this. However, you're not going to get the full size. Estimating the size to the nearest inch is not going to be exact. And when we're talking about things like approximation of wound edges, you have to know the exact size because 1 or 2 millimeters can mean the difference between it eroding or it trying to heal. We need to know the difference. It's that simple. Tracing the lesion into a piece of paper is okay if you don't have a measuring tool, but it's probably going to be a last-ditch effort. Again, the best way to do it is the way that it's outlined and underlined. So memorize that and know what you shouldn't do, and move on to the next slide. All right, so we're going to talk about auscultating lung sounds. Remember all these things that you need to know about auscultating lung sounds. Most importantly, remember, leave the stethoscope in each location for at least 1 respiration. That's it. That's all you need to know as far as that's concerned. Know your little bits and bobs, know your rhythm and how you're supposed to do all your auscultation of lung sounds based off of all the bullets I've just given you. And then once you've understood that, move on. All right, lung sounds. We have gone over lung sounds since the dawn of time. We have killed it and kicked it like a dead horse. We put it to pasture. We've made glue of it. And guess what? I'm going to make you do it one more time. So, know the definitions, know the sounds that go with it. You're going to see it again. It'll be really easy, and you're going to be really happy that I did this final the way I did because this is going to be directly correlated with your exit hesi later on in life when you have to review all of your stuff, and you can go straight to this slideshow, and it will give you everything you need for your exit hesi and for your NCLEX. So know your lung sounds, know how they sound, know what disease process they're related to. I put it all in here for you. It's all right there in front of you. So just read it. And then next slide. And again, you'll notice I have put all of your heart sounds by location. You need to know them. I'm going to ask you. It's really that easy. There's not a whole lot of rhyme or reason I need to give you in addition to this. Just know where those points of contingency are articulated on the chest, and you should be good to go. And let's move to the next slide. Okay, when we're dealing with murmurs, we need to know a couple of things. Know that it's associated with harsh sounding, raspy, machine, whooshing, blooshing, blowing, anything of that nature. Know that if it's after S1 and before S2, it's systolic in nature. Know that your murmur is diastolic if it's heard after S2. Know what the other sounds mean. Know what you need to look out for, and be prepared to have a patient that's going to have some type of deficiency related to this and know how to recognize which one it is. And if you got those, then just move on to the next slide. Okay, related to S3. Please understand what an S3 heart sound sounds like. Please understand that the word Kentucky is mostly associated with the third heart sound, right? So it literally is how it sounds going through it. If you hear it, I would encourage you to give it a Google, an S3 sound. It sounds like the word Kentucky. Okay, that's always very important. It usually is understood in a question in NCLEX style, exit hesi style, specific to the word Kentucky. Please understand that. Please also know what it means to hear an S3. Know what that means if it's a kid versus a young adult versus an older adult. It's all written out here for you, so just pay attention to the slide and the information and understand it. And once you have, let's go to the next one. All right. Please understand that the diaphragm of your stethoscope that is placed over the skin at the mitral area You're also going to be listening to the apical pulse. Please know that they are mutually exclusive in position. Please know that S1 and S2 should be distinguished. Please know you need to listen to it for a minute. And if you listen anywhere else, in any other area, it's not going to give you clear auscultation of the apical pulse because it's gone over in the mitral area, period. All right, also known as the PMI. All right, they have different names interwoven within one another, but they are basically of the same type. So it's like saying my last name is Peters of Ronnie Peters, who is my father, and of, Edith Couch or Edith Snow, depending on how you want to go there, right? So like it's the difference in mom and dad. They're still my mom and dad. They're still mutually exclusive to me. However, they hold a slightly different position just because of the name. I hope that makes sense to you. It should. So let's go to the next slide. All right, when we're dealing with abdominal assessments, we need to make sure that we're holding the diaphragm lightly. Can't press it down too hard, right? Make sure that you hit it for each abdominal quadrant and make sure that you do the technique correctly. Pushing down too hard could change the sound, the tone of the sound, or it could just shut it off altogether. And then you need to know the bell is listened to, or using the bell is specific for listening to sounds of the vascular area of the abdomen, which usually aren't heard. That would be indicative of like a AAA, an abdominal aortic aneurysm. If we had some type of tertiary sound associated with that, that would not be a good thing. So let's go to the next slide. All right, specific to the abdomen, know what things should look like and know what they shouldn't look like. So look at the normal findings, look at the findings, know the difference in the two, be ready to recognize them. That should be good to go as far as this slide's concerned. So let's move to the next one. All right, so slight change. We used to believe that we used to have to listen to every single sound in each quadrant for 5 minutes. It's no longer the case. I got clarification on that. We need to listen to a section for 3 to 5 minutes, 5 minutes being the max, obviously. If we have no sound in that quadrant, listening to all quadrants of the abdomen isn't necessary because all vowel sounds heard in the quadrant, they may originate in another quadrant. So if I have absent vowel sounds at any point for that 5-minute break, just go. You don't need to listen to them all, right? Because the problem is in that quadrant. You need to go grab a doc as fast as you can. We don't have time to measure the length of an ileus or to measure an ischemic bowel because we got to get them into surgery. So this is the way that we're looking at this from this approach from the OBN standpoint. We're looking at it from a triaging them to get to surgery faster, if that makes any sense, versus waiting a whole nother 20 minutes confirming what we already know. All right, so let's go to the next slide. All right, so specific to hearing loss in the older adult, presbycusis, that is the big name for age-related degenerative changes of the inner ear. So what degenerative changes do we have? Well, as a result of the changes, we have a decreased response in high-frequency sounds only. You'll recall a couple of exams ago, I talked about how I made a joke at one of my teachers by using a high-pitch frequency sound, and I said a bad word, and I had it on repeat, but I put it at such a high frequency that only me and the students could hear it, and the teacher couldn't. You'll never forget that because I never got in trouble for it, and I should have. It went awful, and it went on for 2 hours, and it was everything everyone could do to not laugh for an entire 2 hours. But it was the last day of school, and I thought it was funny, and it was a good experiment. So there you go. Low-pitched sounds, however, we're always going to be able to hear it. So it doesn't matter how old I get. Don't try to be slick and mess it up. If it's low-pitched sound, I'm going to hear every bit of it. If it's high, meh. You still got a couple of another years before I finally lose it all together, but you're getting there. So don't play any jokes, and I'm watching you. All right? Older adults will respond to low-pitched tones. Please know that. Being distracted, cerumen production, or what they call like earwax, or changes in the middle ear structure are not related to hearing loss due to degenerative changes in aging. Please understand that. And then we can move to the next slide. All right, so let's talk about toddlers very briefly. These are the things that toddlers are supposed to be able to do. There's a difference between fine motor skills and gross motor skills. Gross motor skills are big things. Sitting up in a chair, walking, holding the edge of a table while you're doing that. Creeping or crawling up the stairs. That's gross motor. Fine motor deals with dexterity. You have to have dexterity to stack blocks to make a tower. You have to have dexterity to stack linking logs together and snap them together, right? That would require a fine motor skill versus a gross. So you need to know the difference in the two of those. And then we can move to the next slide. Again, these are developmental milestones of the infant and the preschooler. Know what your preschooler milestones look like. Know your infant milestones. You're going to have to be able to identify them. And then we can just move to the next slide after this. All right, so playing with infants. We have different things related to the types of play, right? There's types of play, and then there's parts of the conceptual framework of the mind. So during object permanence, if I put something behind my back and you were too young to understand that what is no longer there is simply behind my back, then you do not have object permanence. If you are reaching for whatever it is that I put behind my back, you know that that object has not gone away, so you do have object permanence. Does that make sense? So please understand, if a child is trying to reach for something that I have hidden from them, they have availability of object permanence. They have the ability to understand that there's still something behind my back regardless. Trust versus mistrust, you need to know what that is. Mother-child relationship, please understand that there has to be quality and consistency, and that is part of the bond between the two of them. If there is a break in that bond, there is a break in that relationship, and there will also be a break in commands given through that relationship towards that child or towards that adult even, depending. Know about autonomy in Erickson's developmental stage, and also know about parallel play, and then we can go to the next slide. All right, abnormal findings to the older adult. Know what abnormal versus normal means. Know the difference in the two. Know that you're going to have to identify them. That's really all I have for this slide, because I've kind of laid everything out in a nice little bow for you. So let's understand abnormal versus normal, and let's move to the next piece. Again, when we're dealing with nails, know the abnormal findings, know the normal findings, know what abnormal could mean. Right? So know that brittle nails occur when there's anemia. Know that transverse ridges mean there could be nail trauma. Things of that nature. Know what normal looks like. And then we'll go to the next slide. All right, problems with elimination. Whenever we have problems with elimination, please know what problem could be consistent with that type of elimination. Please know the different types of incontinence. I've pretty much put all of this here for you. Know that if we have someone who has immediate need to go void, know that if that same patient still has problems making it to the bathroom in time, once they've been alerted, that this has to be announced to a physician immediately. This is a problem. This could be many things, but it needs addressed, so we have to get a physician. So look over them, understand them, commit them to memory, understand what's in red, and go to the next slide. It's all here for you. All right, components of a head-to-toe assessment. You need to know these. You need to be able to pick them out of a lineup. And you also need to understand that a head-to-toe assessment is never going to include anything about employment history, anything about payment methods, or credit scores. I'm not here to do your taxes. I ain't got nothing to do with what job you have, and I'm not taking any money from you. So none of those things are ever going to matter to me ever in a million years related to being a nurse. Everything else is, though. So take a look at it, know it, and go to the next slide. Okay. Know that head-to-toe assessments are considered complete assessments. Know that one is synonymous with the other. We have a lot of names that are intercorrelated. I don't know why we do it, but we do, right? We do it with everything. So know what you need to check when you're doing a complete head-to-toe assessment, right? Know what you need to do for the lower legs when you're assessing lower legs, and know that there isn't a test. There isn't a Romberg. There isn't a this or that. That's going to be assessing lower legs specifically, not unless we're doing a brand new infant. We would do a Babinski in that case, or if we're checking for brain death, we would do a Babinski. But know that there isn't like a specific test related to the lower legs, at least not anything I need for you to know that is related to a leg assessment. And then we'll move to the next slide. All right, we're going to go over prefixes and suffixes again. So for nephromegaly, megaly is going to be your suffix, nephro or kidney would be your prefix, right? Megaly means enlargement. Plasty means surgical repair. High blood pressure means hypertension. Hyper means above or over in Latin. Tension means to stretch. So we're stretching above the limits of a normal blood pressure, aka hypertension, aka high blood pressure. See how that works? So just go over those things again. Know that those are the suffixes. Know your other suffixes and go to the next slide. Know when we have patients with nasal cannulas, we have to deal with inspection. We have to inspect their respiratory effort, measure their oxygen saturation. We need to inspect their nares for redness. We need to ask them if they've had any cough, what the color and amount of that is, right? Is it getting in the way of their activities and sleep? We need to check behind the helix of their ears for redness and signs of pressure. This is the number one spot we're going to have wound damage associated with nasal cannula use and it being too tight. So make sure that you check the nasal prongs and oxygen tubing as well for any points of pressure. And please know how to recognize points of pressure. And then you can go to the next slide. All right, when we're dealing with new trachs, you have to inspect the skin around the trach. You have to check it for redness, excoriation, and skin breakdown because you're going to have it. And that skin breakdown is going to cause an infection. That's going to cause sepsis, which is going to kill a person. So here's some information on new trachs. Know the information about new trachs. Know all of that. Know it and also know what you need to watch out for and why you need to watch out for it and what that could lead to. It sounds like a lot, but really it's not. It's like 5 points and something in red. So don't make it too complicated. Understand what I'm trying to explain to you. And go to the next slide. All right, when we're dealing with casts, please understand, we need to check capillary refill. If it's over 4 seconds or over 3 seconds, it's indicative of a compromised circulation issue, which could be compartment syndrome due to the cast being too tight, so it's a big deal. Know your normal findings. It's normal to itch. It's normal. It's compartmentalized. It's going to itch. It's going to slough off. It's not going to be able to go anywhere. It's just going to stack on top of each other, and it's going to create more itching. Normal, right? No temperature and blood pressure are going to have nothing to do with nothing. You shouldn't have an increase unless there's a problem, again, with a result of potential for compartmental syndrome or for pain related that hasn't been fixed. So you have to adjust accordingly, and you have to assess accordingly. But no, capillary refill in excess of 3 seconds that means something's wrong with our circulation. This is a big problem. This is a medical emergency. When you're dealing with surgical wounds, always inspect it for redness, edema, drainage, and intact skin. Never, ever, never, never, never skip over it because you know the surgeon's going to see it. Never ask the patient's family to assess it. Never hand the client a mirror and expect him to do the same. If you've ever done the last two things, you're only going to do it once because you usually make the family sick or you make the patient sick, seeing what they have to deal with, and it overwhelms them. And unless they're trained to do what we do, you should never make that a thing, okay? Unless it's something that they have the wherewithal to handle. And if it's a very brand new surgical wound or it's a new problem with the wound, I wouldn't do that. I would do my basic assessment. I wouldn't try to educate them further, not at least not at that moment. So please understand why we wouldn't do those things and why it wouldn't be beneficial to the patient, and please understand what we would do and why we would do that. And then move on. Next slide. All right, stomas. Know what color they're supposed to be, and know what color they're not supposed to be, and know what that means if it's not the right color. So check your slide, see what it says, and move on. Go to the next one. I think we're done here. All right, related to venous insufficiency. Venous insufficiency. You're always going to have a patient who, when they sit down, after a couple of hours, it starts to hurt their legs. When they get up and walk around, it also starts to hurt. When they go and lay flat, it gets better. The pain goes away. Why? Well, because we're putting the level of the legs at a gradient. We are promoting the free form of that fluid that's stuck in your ankles to then push forward and then go back up to the level of the heart and redistribute as necessary. So please know that we're not going to see this with a patient who has a peripheral vascular issue, right? Like, so a peripheral artery disease is going to be different than a vascular issue or a venous system issue. Please understand that. So when we're dealing with peripheral artery disease, if we have an arterial issue, we are not going to close the legs because we're going to shut off circulation. We're not going to put on TED hose because it's going to cut off our circulation, right? That's when we deal with claudication, intermittent claudication versus full-on claudication. So walking helps the problem related to peripheral artery disease. Walking will make the problem worse if this is a venous insufficiency problem. Please know the difference in the two. Okay, next slide. All right, closed-ended versus open-ended questions. We need to go ahead and hash this out again. So can you share with me what you've been told about surgery? Completely open-ended. Versus, have you received your flu shot this year? Yeah, I have. Okay, cool. Conversation's over. Know that any of these open-ended questions is going to give a response by the nurse that is most likely to stimulate further discussion between the nurse and the patient. And then let's go to the next slide. All right, blood pressure cuffs and false low versus false high readings. Know what causes a false low reading, know how to recognize it. Know what causes a false high, know how to recognize it, know how to separate the two apart. It's going to happen. So that's a rehash of that. And let's talk about heart rate in the next slide. All right, when we're assessing heart rate, know that all of the things you need to do are on this slide. Know that simultaneously we need to feel for pulses while noticing the rhythm. Okay, know this is most important to assessing our heart rate. So go back to all of these points, understand all of those points, be able to recognize them, and also recognize that you feel for pulsations while noticing the rhythm. And then we can go to the next slide. We're almost done. All right, when we're taking oral temperatures, they should be avoided if someone has nasal congestion. Why? Well, because if everything's stopped up, then we're not really getting an appropriate temperature because they're mouth breathing. That's why. So it's no different than me drinking some orange juice. Okay? Know the other methods and know why they are important. Know and understand what I just told you about why we wouldn't do an oral temperature if someone's got nasal congestion. And then let's look at the next slide. All right. No hand hygiene is the single most important thing to reduce transmission of infection. Period, point, paragraph. No contact precautions. What do you need in contact? What kind of patient are you going to have for contact? No negative pressure rooms. What two patients are you going to have? COVID and TB. What does that look like? What do you need to do before entering the room? What do you need to do after the room? What do you need to wear? What order do you wear it in? Know all of these things related to PPE, period, point, paragraph. And remember, if a glove breaks during a procedure, you have to replace it immediately. I feel like all that's common sense. So know that slide. And then let's get into the math, and I think we'll be about done with this. Okay, so rounding. 3.85 to the nearest tenth. Let me get my little pointer out. Let me get my little writer out. So this is going to represent our tenths place right here, okay? And this is the little buddy that we check. Now, that little buddy is 5 or higher. So we simply take it over here, that extra number, and we make it 3.9. Done. All right, next slide. All right, let me get my little drawer ready. Here we go. All right, so if there are 100 milligrams in 50, oops, that's ugly, sorry guys. 100 milligrams in 50 mLs. This is some head math, I think. Yeah. Then there are blank milligrams. Let's do milliliters here. Ooh, and the milligrams, y'all just bear with me. Remember, I don't have a stylus. Milligrams, all right, cool. Then there are blank milligrams in blank milliliters. So now we have blank milligrams in 25 milliliters. Well, honestly, here's how this works. If I have half here and half here, 50 divided by 2 is 25, then all I do here is 100 divided by 2, and that gives me 50. Done. That's how that works. It's really that simple. So 50 is my answer. Right? Because if I got 50 milliliters and it's got 100, then I'm just going to have half off 25. All right, next slide. Okay, so a client accidentally spills 50% of their medication. That's half. Medication originally contained 80 milliliters. How much medication remains? Well, 40 does, duh. That's head math. All it is just divided by 2. Or we could do it the hard way, which is percent or 50, because there's a percent next to it, over 100. Is, that's my equal sign, sorry, which is the is over of method. So is would go here, and then of would go below. So 50% of 80 milliliters is how much? And then you would simply just cross multiply. And then you should get, what is it, 4,000 should be blank, blank, blank. And then you divide that by the 100x, if we're solving for x, I guess. And then that should cancel out that 0 and that 0 when you divide. That should cancel out that, and then you should still remain with your 40. Boom, done. All right, next slide. Okay, convert 0.56 milligrams to micrograms. All right, 0.56. 56. All right, so we're going from milligrams to micrograms. Milligrams is bigger, so milligrams is over on this side. And micrograms is tiny, so micrograms goes on the tinier side. Because much like numbers, we go 1, then 0, and then we go to -1. See how we go ascending to descending, right? That's the direction we're going in, from big to small. Same deal here. So then we would just go 1 spot, 2 spots, 3 spots, because that's how many spots you go. So milligrams to micrograms is 3 spots to the right, and you got 560. So that's your answer. And next slide. And I think this is our last one. So we're going to convert 1,258 micrograms to milligrams. We need to do that first. So 1,258 goes like that. Cool. And there's a kind of a period and a 0 right here. Now, when we're going from micrograms to milligrams, we're going to go this way. Because we're going from smaller, mcg. Ooh, that's so ugly. Sorry, guys. mcg. And then we're going to milligrams, which is bigger, so we're going this way. All right, so then we go 1 spot, 2 spot, 3 spots. This becomes 1.258. Ooh, not my prettiest numbers, guys. Oh, these are so tragic. Got to get one of those pens. All right, 1.258, cool. Now we're going to round, now that we've done that, to the nearest 10th. And our 10th place is this guy. So we're going to go next door and look at this guy. Now this number is 5 and higher, so we're going to do +1, +1, and we're going to put it right over here. So then that number becomes 1.3, and that's milligrams. Okay, that should be everything that you need to know math-wise, everything you need to know everything-wise. Pay attention. We have a Zoom tonight. We got a Zoom on Thursday. Both are 9 p.m. to 11 p.m. If I need to do one in between, I will. Just send me a text message. All right, guys, this is it. I love you. I'm proud of you. You guys are going to do great. And Friday's going to be a great day. So we'll see you then.